Hello, everyone. Thank you for participating in this webinar. I hope everyone is well and staying safe. So, my name is Nguyen, and I'm a faculty in the School of Pharmacy. So the purpose of today's webinar is to give you a brief introduction to health economics evaluation. So before I go into the technical details of how we're going to do health economic evaluation, so let me begin with some example just to motivate why we need health economic evaluation. So this slide shows you some of the latest technologies in the medical sector. So these range from the heart transplant to genomic sequencing to the use of gene editing and even the use of drone to deliver medicine and healthcare. So no doubt the technologies can improve health and save lives. So it might work wonder, but these technologies are not cheap. So when you think about whether we're going to adopt these technologies, a question immediately arises. Will these technologies offer good value for money, right? And this question is particularly relevant given that we don't have unlimited healthcare resources. And on top of that, at the moment, over the past few years, we're facing a big challenge for almost every country of a fast rise in healthcare costs. So we need to do things to control the rise in healthcare costs. And even if all the technologies offer good value for money, then still we cannot spend resources to adopt in every single of these technologies. If we spend on one technology, maybe that is the money that we cannot spend for other stuff. So we need to be selective, right? And so this is where health economic evaluation comes in. It allows us to compare the costs and the benefits of different interventions, different technologies, and then it determines which one will offer the highest value for money. Or in other words, which technology going to offer the best bang for the buck. So that's why health economics evaluation is very important, and it increasingly adopted in these days where we try to increase the values in healthcare, where we try to reduce the healthcare costs. Okay, so the COVID situation offer another example why we need economic evaluations. So you probably heard of the drug called remdesivir. So this drug is being used to treat patients with COVID, and this is very effective. It can reduce the risk for severe COVID, and recently it has been shown to work against the Omicron variant as well. But this drug is very expensive. Only 5-day treatment costs over $3,000 in the US and similar in Canada. Then the question arises: is it worth it to use this drug to prescribe to patients? Especially at the moment, we have some other drugs that has been launched to treat COVID. So yeah, this is where health economics can help. Here's another example that related to the topics, social determinant of health, that have attracted a lot of attention lately, especially in our province. So nowadays, over the past few years, and especially recently, you have policymaker, public health professional, they talk about how health can be affected by the factor that not specific to health, like education, economic stability, characteristic of your neighborhood, the social context, and this is on top of the agenda at the moment for our province. So recently, the Health Accord NL report emphasized the need to invest in several social areas to address the issue of poor health and health inequality. So we talk about improving food security, health insecurity, to build a more inclusive health system, provide better education and care for children, or create a community that of aging friendly, and so on. But as soon as you're talking about sort of try to invest in this social area, then the question arises. We need to identify effective and cost-effective interventions, right? That can promote social determinants. And therefore, you're going to need health economists to help you with this. And actually, recently, only last week, I was contacted by members on the Health Accord NL team, because she's looking to evaluate the cost and effectiveness of some interventions to target the social determinant of health. So health economic evaluation is very relevant. All right, so with that, I'm going to spend probably 30 to 40 minutes to hopefully to cover these topics. So first, I'm going to introduce you to some basic concept in economic evaluation. In particular, it's very important that you understand the concept incremental cost effectiveness ratio, ICER in short. So this is the main metrics of cost effectiveness. So it's important that we understand and what it is, and how to calculate this, and how to interpret it. And then I'm going to explain to you how we are going to determine an intervention is cost effective or not. So very often we heard about this intervention, this technology is cost saving, or that technology is cost effective. So what is the difference between cost saving versus cost effective? So I will cover that. So after that, I'm going to talk about how you go about estimating the cost and estimating effectiveness. But at the end of the day, to do cost effectiveness, all you need to do is to estimate the cost, to estimate the effectiveness, and you block it in a formula for ICER, and then you obtain the ICER, and then there you go. So it actually quite more straightforward than you think it is. And I'm going to end up with by going through two examples of economic evaluation, just to illustrate how you can do economic evaluations. Okay, so what is economic evaluation? So economic evaluation is defined as a comparisons of alternative strategies in terms of their cost and consequence. Okay, so the first thing that I want to draw your attention to is sometimes people say we will use the word strategy. Some other time they use intervention. Some other paper they use options or course of action. So they can be used interchangeably. Okay. So what are the alternative strategies? So they can refer to any intervention that you're interested in. It can be a new drugs. It can be a new surgical intervention. It can be some public health program. Well, if you think of in terms of the COVID, right, it can even the strategy to reopen the economy, for example. Costs refer to the real resources that used in the intervention to generate the outcome. And the consequences just refer to the effectiveness of the intervention or treatment that you're looking at. It can be positive, such as extended lifespan, but it can be negative as well, such as adverse events. So there are two things I want you to remember to notice about this definition. First, as you can see here, these alternative strategies, right? So what it means is that economic evaluation always involve a comparison of different strategies, a different intervention. Okay. So when we say intervention A or a drug A is cost effective, we always have to be clear about A is cost effective versus what, right? So we never say that, oh, this surgical procedure is this new drug is cost effective. We always have to say that, oh, this new drug is cost effective versus X. So we have to be specific about that. An implication is that because economic evaluation is a comparison, so there is no need to say A is more cost effective than B. We don't say that. We just say A is cost effective versus B. That is enough. There's no need to use the word more is more. Okay. And before I go to the next slide, I want to know that economic evaluations and cost effectiveness analysis are often used interchangeably. Okay, so when people say cost effectiveness, then you know that is economic evaluation and vice versa. So I find it useful to think about economic evaluation as in this way. So there's just two things that you should keep in mind. So economic evaluation is just a tool that you can use to determine which intervention provide the highest value for money. That is the purpose of economic evaluation. And how do you do that? Well, you do that by quantifying and comparing the costs and the benefits of the intervention that you are comparing. Okay. So there are different types of economic evaluation. I list three main types here: cost minimization, cost benefits analysis, cost effectiveness analysis, and cost utility analysis. So these three types are differ in what outcome you include in the analysis and how the outcomes are measured. Okay. So the difference between cost minimization and the other type is that, as the name suggests, cost minimization just focus on the cost alone. Okay. Suppose you want to compare two drugs, then you can do the cost minimization, and you can argue that, look, these two drugs have similar effectiveness, have similar efficacy. So I'm just interested in knowing which drug is cheaper. Okay, so for that scenario, for that purpose, you're going to do the cost minimization. Okay, and you normally you do cost minimization only when your interventions of interest have similar outcome. Okay, have similar effectiveness. So you don't need to worry about different in effectiveness. You worry about the different in cost. Okay, so that is the difference between cost minimization versus the other types of analysis. Now, between 2 and 3, what is the difference? So cost benefit analysis and cost effectiveness analysis differ in the sense that for cost benefit analysis, the outcome, the effectiveness is measured in terms of dollar value, where in cost effective analysis, the effectiveness can be measured in anything, in non-monetary effectiveness, such as a number of infections, such as a life year saved, for example. Okay, so for number 2, the effectiveness is measured in terms of dollar value. For number 3, the effectiveness is measured in non-monetary value. All right. Now, in category 3, we need to distinguish between cost effectiveness analysis versus cost utility analysis. And the difference is that for cost utility analysis, effectiveness will be measured by quality adjusted life year. So it's very unique in the sense that cost utilities analysis, CUA, focus on quality as the outcome, when cost effectiveness analysis can cover any types of outcome as long as it's not in monetary value. So in this webinar, I'm going to focus only on the third category, the cost effectiveness analysis, and a subset of that, cost utilities analysis. And the reason for this is that this is the most popular cost effectiveness analysis. All right. So I talked about ISO earlier. So let's go into detail. What is the how ISO is calculated? So ISO is the main metric used in economic evaluation. It's routinely calculated and it and report in cost-effective analysis study. So it is important that we understand this metrics. So in terms of calculation, so ISO basically it's just a ratio between the difference in cost of the two intervention or two treatment divided by the difference in the effectiveness between the two treatment. Okay, so on the top that the difference in cost, and the bottom that the difference in the effectiveness. So I give you one example. We want to estimate the ISO that involve the comparison between two drugs, the current drugs and new drugs. So current drug costs $5,000, and in terms of effectiveness, it can increase life expectancy by 1 year. The new drug come in. The new drug will launch, and we know that it's cost 10,000 K, which is twice as expensive, and it increased life by 2 years. So what is the ISO from these comparisons? So ISO will be 10K minus 5K divided by 2 years minus 1 year. So that equals 5K per year. Okay. So how do you interpret the ISO? So you can think of ISO as an extra cost or extra price that you have to pay to get one extra unit of outcome. All right. So in this case, the new drugs cost more, but also offer you more. And also the extra price you need to pay. You need to pay $5,000 more to get 1 more year's of life. Okay, so that is the way we interpret the ISO. ISO can be think of as the extra price of obtaining the price you need to pay to obtain 1 extra unit of outcome. Okay. Now I mentioned earlier about the fact that we often, we sometimes we come across with the people say whether it cost saving or cost effective. So what is the difference between these terms? So it's useful to distinguish these two terms in this frameworks of ISO. Okay, so I showed you the ISO calculation formula again. That is again is the difference in cost divided by difference in effects. So there are 2 scenarios here when you compare the cost and benefit between treatment A and treatment B. All right. So suppose you have a treatment B. You have a new treatment that it costs less and offer better outcome. Right? And this you can think of it is like computer, like laptop. For laptop, normally the price going down over time, and it's faster, it's more powerful, right? So this is an ideal situation. You want a new technology that can offer you more but cost less, right? So so for this scenario, we're going to say that A is cost saving versus B. Okay, A is cheaper and it offers more better outcome. Therefore, A is cost saving, and there's no need to calculate for either in this context, right? Because if a cost say if it is cheaper, when you plug in that ISO formula here, because the cost here is cheaper, then when you take the difference, the ISO will be negative, right? So there's no need for the ISO in this context. Okay, so cost saving occur. We will use cost saving when you compare two interventions, and one intervention is cheaper but offer better outcome. This is the dream scenario, right? We want this. However, in real, most of the time, we don't have that kind of free lunch. Normally, we have new technology or new intervention that is cost more, cost of A greater than cost of B. And it's also offer more, it gives you more, but it's also cost you more. So this is the situation we often encounter in practice. You have new drugs, it works better, less side effects. Unfortunately, it just costs more. Okay. So for this scenario, which is very popular scenario in real life, we're going to distinguish between two sub scenario. We estimate the ISA because for this scenario, or for A, for cost A greater than cost B, and effectiveness of A greater than effectiveness of B, we can estimate the ISA. Okay, it's not like for the previous case where we cannot estimate the ISA because the ISA is negative. So for this case, we often estimate we calculate the ISA, and then we need to determine whether it's cost effective or not, because A is more expensive and offer better outcome. But then the question is whether it is a cost effective versus B or not. So there is a rule that allow us to tell whether A is cost effective versus B or not. And the rule is that we need to compare the ISA versus a benchmark. And this benchmark is called a willingness to pay. Okay. So so basically what it means is that, okay, so you come up with, we have a new technologies. And with these new technologies, we compare with the old technologies, we estimate the ISA. And remember what ISA is. In the previous slide, ISA is just a price, right? The ISA is the price that you need to pay to get one more units of outcome, right? And then if the price is too high, and in this context, it's more specifically, it's higher than the willingness to pay, then we're going to say, look, this technology is too expensive. In other words, it's not cost effective, right? And if the ISA is lower than the willingness to pay, then we say, yeah, look, then this is good. The price of new technologies is reasonable, so it's cost effective. Okay. Then that still leaves the question, so what is the willingness to pay? You can think of willingness to pay is like the maximum amount the society is willing to pay for one more unit of health outcome. Okay. And the different willingness to pay depends on the country. So the most common one in North America, we used to use $50,000 per quality, and more recently, we tend to agree that $1,000 per quality is a reasonable willing to pay threshold. In UK, they don't use a specific number, they use a range between 20,000 to 30,000 pounds per quality. In developing country, they use a different threshold, and WHO says anything less than 3 times of GDP per capita is the cost effective. Okay, so keep in mind that the willing to pay threshold is like the maximum amount that a society willing to pay for one extra unit of outcome. And in this context, the extra unit outcome is one more quality. And I'm going to go into more detail what is the quality, but you can think of it as like one life year with full health, okay? So the society willing to pay for $100,000 for one extra life year with full health that the new technologies can give us. If the technology has an answer at a price that exceeds this $100,000 per quality, then the technology is too expensive. And in more formal way, I'm going to say that the technologies with the answer more than 100K per quality is not cost effective. Okay. Is there any question so far?
There's nothing in the chat yet. I don't know if anyone has any comments or questions.
I have a quick question.
Yeah, sure. Go ahead, please.
Yeah, I'm wondering, I guess, who decides that in this case it's one extra year of life versus, say, quality of life? I'm just thinking if you have one extra life, but it's really miserable, but you have 4 extra months of really great quality of life. Yeah, who decides what 1 unit of health equals, and why is that?
We have a method, and I'm going to go into that in the later slide, where we're going to estimate the amount of quality, the amount of extra quality that we can get from any interventions. So we have the method to do that. So suppose you give a drugs to the patient, we follow the patient over time, and we use different techniques, and these different techniques are going to give you the qualities for that patient for that month. Okay, so for this month, you follow up, you ask them some question, and then you note down, you get some number for the quality for that month. For next month, you do the same thing. So you do this over time, and then you add them up. Right? And then that's going to give you a measures of the quality. So the person might live for 5 years, but the quality actually only 3 years. So we have the method that can capture not just the length of the time that you live, but also the quality of life during the time that you live.
I'll wait and see if I have any more questions after you talk about the method more. Thank you.
Thanks. By the way, feel free to interrupt me anytime if you have questions. So now I'm going to talk about the components of cost effectiveness analysis. So again, up to this point, just want to remind you that it's very important to understand ISA. Right? The ISA is the main metrics of cost effectiveness analysis. If you are able to estimate the ISA, then you're almost done with your cost effectiveness analysis. And ISA is actually simple as you can see from the formula. You just estimate the cost of intervention A, cost of intervention B, to the intervention that you're interested in. You estimate the benefit of intervention A, benefit of intervention B, right? You take the difference between the difference in cost, and then you divide it by difference in the benefit. Then you have the ISA. But have the ISA is not enough, right? Suppose you estimate the ISA like 45K per quality. How can you tell whether the intervention is cost effective or not? You always have to go to the other step, which is you compare the answer with the willingness to pay threshold. Okay, and remember, in different countries have different willingness to pay threshold. So, but normally, I mean, we use 100K per quality. So if you estimate the answer of 50K, then you can safely conclude that the intervention I'm looking at is cost effective. All right. So now I'm going to go to a little bit more detail, because I'm talking about estimated cost, estimated effectiveness. But how do you do that? So this is so this next few slides will cover this. So in terms of the cost, it's important to distinguish different types of costs that you want to include in the calculation. So we distinguish between direct costs and indirect costs. So direct cost, you can think of it, I mean, in the simple way, it's any cost that measured in dollar value, okay? While for indirect cost, it has another, the name is productivity loss. So it's measured by the time that you lose. Okay? Suppose you get sick, you cannot go to work, so you lose productivity. So there is a cost there, and the cost is measured in terms of the time lost. Okay. So for direct costs, we further distinguish between medical costs and non-medical costs. So medical costs, as the name suggests, it includes all medical costs, such as the cost of the drugs, cost of hospitalization, cost of lab tests, so any cost that related that are medical. And then there are non-medical costs that you should take into account as well. I suppose you ask the patient, your intervention is some kinds of new lab tests, right? So, or some kinds of surgical procedure. That is your intervention, and you want to study cost effectiveness. Well, when you do that, you need to take into account not just the medical cost of the surgical procedure, but you also need to take into account the cost of the transportation for the patient to go from home to the surgical center, right? And they also cost of the social care, so people need to take care of you. So you need to take into account those non-medical costs. So for indirect costs, again, it just refers to the time cost. So normally it includes the time that you have to take, the time that you take off work to receive the treatment, or the time you spend to travel between your home to the clinics. And if you have some side effects, you end up in the hospital, then you need to take that into account as well. So some new intervention and new drugs is very effective, but at the same time, it has severe side effects. It might make you end up in hospital for some time. Then you need to take that into account, because that is part of the cost of your intervention, right? But for cost effectiveness, again, when you do the answer, the cost should be measured in dollar value. So after you estimate the time lost due to the intervention, you need to convert it into dollar values. And the way we do that is normally we multiply the time loss with some kinds of wage for that person. So if you work, if you're 45 years old, so we normally make some assumption that how much you make per year, and then we convert into how much you make per week. And then if you spend 2 weeks in the hospital because of this intervention, then you just multiply by 2 weeks by the average wage per week, right? And that is the monetary value of time loss, and that should be counted into the cost of your intervention. One important thing you need to consider when you calculate cost is the perspective. So for every cost effectiveness analysis, you need to be very clear at the beginning what kinds of what perspective you are taking. Whether you take in the perspective of the healthcare system, like the Canadian government, will you take in the perspectives of a payer, such as an insurance company, or you take in the perspective of the whole society, right? So the difference between the health and the two main perspectives that we often use are the health system and societal. And the difference between this perspective is that for health system perspective, you only include the healthcare cost. Okay, you just focus on this medical cost most of the time. Yeah, for if you do the if you adopt the health system perspective. However, if you adopt the perspective from the society, then you need to include all types of costs, not just medical costs, but also non-medical costs and also the time cost. All right. So it depends on the perspective that you take. Another important thing to remember in mentioning the cost is the choice of time horizons for your analysis. So normally in the cost effectiveness analysis, you don't just look at the immediate cost and immediate benefits of the interventions. Instead, you always need to consider cost and effectiveness of intervention down the road. And the reason for this is that there are often interventions that cost a lot immediately and in the short term, but only generate the benefits in the long term. Think about bariatric surgery, which is the surgeries for people with severe obesity. It's a very expensive procedure. So it costs a lot in the first few weeks. However, you don't see a drop in your weight right away. It takes time, years, several years down the road. So if you conduct your analysis and only account for the cost and benefit within just 1 year of the surgery, then you will never find the bariatric surgery to be cost effective, right? So it's very important that you choose the right time horizons that can fairly reasonably capture the cost and the benefits of your interventions over time. And very often when we look at medical intervention in the context of chronic disease, and you know that because the chronic disease is long term, right? So normally we use the lifetime time horizon. So that means we study from the time that you give intervention and you follow the patient all the way to death. Now I give you one examples of how we do the cost estimation. So the context is that we want to study cost effectiveness of a surgical procedure. It's called bronchial thermoplasty. So this is a recent medical procedure to treat severe asthma. So patients normally get bronchial thermoplasty over the course of 14 weeks. Okay. So we need to capture. We need to try to capture the direct medical cost. So for direct medical costs, we definitely want to capture the cost of the procedure, right? Definitely want to do that. We want to also capture the cost of the medication over time. And suppose that 3 months later, after you receive this procedure, there's some asthma exacerbation that require you to go to hospital. So you need to capture that as well. And over time, there's some follow-up visit, so you need to capture that. So all of these need to be included when you estimate the cost associated with bronchial thermoplastic procedure, when you do the cost effectiveness analysis. Okay, it's not just the cost of this procedure. No, you need to capture the cost of the intervention and all the related costs over time during the time horizon that you choose for your analysis, right? Suppose what happened if you decide not, or you missed including the cost of hospitalization at 3 months after an asthma exacerbation. Then you're going to get a biased result. Because what if this procedure helped to reduce exacerbation over time, right? If the procedure reduce exacerbation over time and you don't capture that, then you underestimate the benefits of this procedure. You also need to capture, and those are the medical costs. You also want to capture the direct non-medical costs. You see that I put the car here because you need to pay for transportation to go to the surgical center. Right? You need to pay for transportation again if you have hospitalization sometime down the road, right? And then every time you go to hospital to receive these procedures, or you end up in hospital, you take time off work, right? So you need to take that into account as a cost as well. Okay, so this is indirect cost, productivity loss, right? Because suppose there are procedures that work very well. However, it requires a lot of follow-up visit over time. So that actually a cost that you want to take into account. Or if the procedure is very expensive at the beginning, however, it reduced the risk of asthma exacerbation down the road. As a result, you don't need to go back to hospital often because you don't have exacerbation often. So that's a huge benefit, and you need to take that into account. You need to take that into account. So this is one example of estimating the cost, where I show you sort of direct medical costs, direct non-medical costs, and indirect costs, or another name for it is productivity loss. Is there any question on this?
Not in the chat, but I don't know if anybody has anything they want to ask.
Okay, so let me move on to effectiveness. How do we measure effectiveness? So there are different measures of effectiveness, right? It can measure in terms of like death, or death averted, or morbidity. Some example is here: episodes of illness, infection, number of cases prevented, hospital length of stay is also a possible outcome. You can look at the life years as the outcome, but the most important and the most popular outcome that we often look at in cost-effective analysis is the quality adjusted life year. And I'm going to talk more about this. So what is quality? So quality is a measure of the disease burden, a health outcome that combine the quantity of life and quality of life. So it's calculated as the product between the number of years that you live and the quality of life in those years. So the quality of life. So first, the quantity of life here is very easy to measure, right? Because you can observe how long that person lived. So that's the first component. The second component is utility. Another name for this is quality of life. So they use interchangeably. Quality of life and utility value or utility score, they mention the same thing. Okay. So now I'm going to talk about how we're going to estimate, how we're going to calculate the quality of life here. As one participant asked me earlier. Okay, So there are different ways, there are different methods to measure quality of life, but one of the most common way to and very simple to do it is an instrument called EQ5D. Okay, so EQ5D is just a survey, and it asks the patient, it tries to capture how well a person is doing in 5 aspects of health. That's why you see that EQ5D. EQ is for European quality, so because it developed by some European organization, and 5D means 5 dimensions. Okay, so it tries to capture how well a person doing in 5 aspects of life. And these 5 aspects of life are anxiety, depression, one, mobility, another one, self-care, usual activity, and pain and discomfort. Okay, so they got to ask patient a question for each of these 5 aspects, and there are 3 response choice for patient. The patient can say, oh, I have no problem with mobility. I have some problem with mobility. I have major problem with mobility. Okay. And EQ5D has been estimated for several illnesses, and it has been verified. It has been validated in several countries. Now I'm going to give you one example how you can operationalize this. Okay, so this is the survey, right? There are 5 dimensions. Each dimension you have 3 choices here. So this patient choose to answer, oh, he picked a number 1 when he asked about mobility. I have no problem in walking about. I have no problem with self-care. I have some problem with performing my usual activity. I have extreme pain or discomfort, and I have moderate anxiety, anxious, and depressed. So for this patient, the answer is 1, 1, 2, 3, 2. All right. So this answer is of this patient is coded 1, 1, 2, 3, 2. Then the trick is that this survey, the EQ5D, come up with an algorithm. Okay, it can convert any answer into a utility score, into a value that indicate the quality of life for that patient. Suppose this patient say 1, 1, 2, 2, 1, then the algorithm say that, oh, his quality of life is 0.76. Which means that the person lived in that year, he lived for 1 year, but the quality of life is only 0.76 years. Okay, so the quality is 0.76. If the patient answer is 2, 3, 3, 2, 2, so then the utility, the quality of life is only 0.079. So this is the ways that we estimate the quality of life. Do you get that? Is there any question on this?
Any questions?
So we have used that EQ5D to estimate the quality of life for patients of different disease. And as you see here, if you have perfect health, then quality of life is definitely 1. For type 2 diabetes is 0.85, epilepsy is 0.83. If you apply the quality of life going down to only 0.37, and that of course is equal 0. Okay. So now I'm going to go to give you some 2 examples, but before I do that, I'll just quickly go through the sort of the procedure, the process, the number of steps that we normally go through when we do the cost effectiveness. First, you need to identify the research question, definitely. You need to identify the intervention that you're interested in to do that. For that, you want to study cost effectiveness. But then, as I mentioned earlier, cost effectiveness analysis is all about comparison, right? So if you're interested in intervention A, the next step you need to do is to identify the comparisons. What strategy you want to compare, okay? So you need to identify your intervention or interest, and then you need to identify the comparison intervention. Okay, and then you need to see what has been done in the literature about your intervention. Maybe it's already been done, so you just need to review the literature instead of doing something new from the scratch. Then you need to build a model. So this is outside the scope of today's introduction, but not most of the time you need to build an economic model. And then you need to collect the data to estimate the cost. Of course, when you do the cost, you need to specify what perspective you're using, what is the time horizon, right? And you need to collect the data on the effectiveness. And then you plug the cost effectiveness into the ISO, okay? And when you have the ISO, you're almost done, because you only need to compare the ISO versus some willingness to pay threshold, and normally it's 100K per quality, right? So the challenge mostly lie in building the model and then try to estimate the cost and effectiveness. But it can be done. It's not a rocket science. It's not that difficult. But when you get to the ISO, then you're almost done. So now I'm going to go to what I'm doing next is to give you two examples. So I talked about the remdesivir earlier. So here is one a study that looked at the cost effectiveness of remdesivir. Okay. So this study published recently in Value in Health in 2022. So we want to know whether it's cost effective. So in this study, the author compared remdesivir versus the placebo. Okay, and they build a model. And the model in this case is a decision tree, because it looks like a tree, you know. And normally the model going to help you to see all the clinical pathway, all the possible clinical pathway for each intervention. For example, for each intervention, you need to specify the different event, whether the patient hospitalized, whether the patient end up in ICU without ventilator, whether in ICU with ventilator, and if the patient in hospital, whether he's recovered or whether he's dead, right? So we need to, when we build the model, we need to specify all the possible clinical event and pathway. And why do we need to do this? We need to do this so that we can identify what kinds of costs, what kinds of benefit we want to capture. So, but when you look at this, you know that, oh, we need to capture the cost of hospitalization, the cost of ICU, right? And we need to capture the loss of a quality of life if the patient end up in hospital. So the model going to help you in that aspect, okay? And for this study, they look at a lifetime horizon. In terms of study population, they look at a patient with moderate to severe, as well as mild COVID. And the perspective is healthcare payer. So here are some of the costs that they capture in cost and effectiveness they capture this study. Okay, in terms of direct medical costs, the cost of remdesivir, but it's not just that. You need to capture the cost of hospitalization. Okay, some people who even you give them remdesivir, they still end up in hospital. So they capture all of these hospitalization costs. I have a question here. So there's no indirect cost in this study. You know why? There's no indirect. This study do not capture indirect costs in this study. And the reason for this is that, well, because they look at the healthcare payer perspective, right? They look at from the healthcare system perspective. It's not the societal perspective. So when you look at healthcare system perspective, you only need to include the medical cost. Okay, so it's important to specify what perspective you want to look at the beginning of your study. In terms of effectiveness, you want to capture the loss of quality of life if you have the COVID symptom, how severe it is. you want to capture a lot of quality of life if you have to be admitted into the hospital. And of course, if you're unlucky, if there is death, that means the life the life year going to be shortened substantially. So you need to capture that as well. So these things are the main measure of effectiveness. So here's is what the result look like. So they do the analysis for two study population. One is for people with moderate to severe, and for this, and if you look at the row in the red color, you see that the cost of remdesivir is almost 4,000. When you take these drugs, it's reduce the risk that you end up in hospital, and that will lead to the saving of almost $2,000. It increase a little bit of your quality of life. So you have this information, and here you have remdesivir plus SOC. SOC means standard of care. So this is your intervention, and this is SOC means standard of care, which is your comparison strategies. So you take the difference, okay? This is the difference in the cost. This is the top part of your ICER formula. You divide it by the total quality, which is the difference in effectiveness, and you get to this number. This is your ICER, almost $300,000 per quality. And you do similar for, this is for the moderate to severe population. You do similar for the population that just only have mild COVID. You do same thing, and the ICER is nearly $2 million per quality. Okay, so if you compare with the willingness to pay threshold of 100K, this drug is not cost effective. To be able to be cost effective, this drug need to reduce the price. And they conduct that kind of analysis, and they say that if the drug, if the price of the drug is reduced to the range of $2,500 to $3,000 for moderate to severe population, to $70 to $220 for my population, then the drug will be cost effective. But at the moment, the drug is not cost effective because it's so expensive. Yeah. Okay. The ICER is way beyond the willingness to pay threshold of 100K per quality. Any question?
No, I don't believe so.
Okay, I'm going to go to another example. So this example related to the example I gave you earlier about the social determinant of health. I think it would be interesting and also very relevant for the context of our province at the moment. So in this study, they look at the cost effectiveness of different interventions that try to target social determinants to social determinant of health to improve the cancer screening. Okay. So just a very brief context. So the rates of cancer, so people are supposed to do cancer screening on the certain frequency, but in reality, you see that there are large disparities, especially by income. So if you look at the figure here, the people who have low income and also the people who do not go to get the screening, they have a very low rate of screening. Okay, and this figure on the right side showing that the people, Hispanic people, some minority demographic population also have a lower screening than the white group. So apparently there's something going on here, right? Because this screening is free of charge. It is already covered by insurance, but some demographic have much lower than the other. So we need to address that. And so it turns out that there's a lot of barriers for people to get screening, and And you can think of this. These are some of the examples of the barrier. But people were not aware of the importance of screening. They might lack the resources for making a trip to the screening center. If they want to go, but they don't have someone to take care of their children, they speak different language, or they fear about sort of this procedure, the outcome that happened after this, after they find out that they have a positive test, right? So there are a lot of barriers here, and this thing is mostly from the social economic angle. So this is where this study tried to address. This state, New Hampshire, tried to address, and the intervention is that they offer a service that run by nurse, trained nurse. So these nurse work with this patient. They try to identify the barrier that that prevent patient from getting screening, okay, and then try to help the patient to overcome this barrier, right? So this not provide education about the importance, the benefits of screening. They try to help, to try to facilitate the appointment, right? So so they do a lot of things to try to help these people, and so that's why the intervention called patient navigation. So what happened is that they basically tried to do 3 times. So the patient had 3 opportunity to get engaged in this screening model, right? If the patient failed the first time, they don't get the screening first time, the nurse is going to try to help them to reschedule the appointment to a second time. And then if that doesn't happen, they schedule the patient for the 3rd time. So the nurse work with the patient, try to engage them in this process for 3 times. And the goal of the patient navigation is to minimize the number of time that the patient drop out of this process. So they try to increase the uptake of the screening, okay? So here are the table in terms of the cost and in terms of the benefits. Okay, so the cost, you need to take into account the cost of the screening, the cost of training the nurse, right? On the effectiveness, you see, they measure by the rate of screening uptake, right? And they compare between 2 interventions of the patient navigation versus the usual care. For the usual care, there's no help from the nurse. For patient navigation, there's a nurse who help you, okay? And you can see that here, the uptake rate of the screening is much higher, 90% versus 53%, 94% versus 65%, okay? So apparently, the patient navigation had increased the willingness of these people to take screening. So you plug that into the answer formula, and what you get here is that the answer is $550. They look at 2 scenarios here. One scenario is $550, the other is $700. Bear in mind that in this context, the outcome is not measured in terms of quality. The measure in the measure effectiveness in this study is in terms of per patient screen. Okay, so in principle, there's no willingness to pay threshold here. However, this author go to the literature and there are actually some study before this. They say they established a willingness to pay threshold, which is about 1,000 to 1,500 per patient. So that is the willingness to pay. This is the amount the society willing to pay for one patient, one more patient to get the screen. Okay, society willing to pay 1,000, between 1,000 to 100,000 or $105,000 if you get one more patient to have this screen. And the answer is, well, way below, or the answer is below 1,000 threshold. As a result, we can conclude that this intervention, this patient navigation intervention, is cost effective to help to address the social determinant of health. and increase their screening uptake. So maybe I think this is probably one of the good examples for our province to look at if they want to identify the cost-effective intervention to target the social determinant of health. So this is my last slide. So just to summarize, this is a need, and there has been a need, the increasing need to improve the value in healthcare, especially we face the challenge of increasing healthcare costs, right? So we need to be able to adopt, to identify, adopt the intervention, the policy, the program that offer the best bang for the buck, and cost effectiveness analysis can help with that. Because what it does is it comparing the cost, it estimate and comparing the cost and effectiveness of different intervention, and it can come up with a way, which is the answer, that allow us to rank the interventions by their value for money. And this has huge, it has a lot of application in several sectors. When you look at the cost of drugs, cost-effective device, cost-effective pharmacy service, cost effectiveness of even public health intervention, just like the one that I just showed you in terms of addressing the social determinant of health. So that's what I have to say today. Apparently, this is just a gentle introduction because I haven't talked much about in terms of using the model to do a formal job of sort of calculate the cost and effectiveness. But at least it gives you a flavor of what the cost effectiveness is all about. And I hope that it can help you to understand, at least read the paper on cost effectiveness analysis, understand what's going on, understand what is ISA, how cost and effectiveness are measured, right? And if you're interested to learn more, I encourage you to find out more about what the next step is to try to learn about the model to do the formal job of estimating cost and effectiveness. So thank you very much. How I'm doing in time. Sorry, I think I exceed some time. If you have any question, you can let me know.
Thank you, Hai. That was a great presentation. And thanks for explaining everything so clearly and thoroughly. Yeah, are there any questions? No, I don't think so.
It's in chat or something. Okay.
Got a few comments. Thank you for the interesting session. I just have to share my screen with everybody. Oh, do you mind stop sharing?
Do you want me to stop sharing?
Yes, thank you. Most of you probably already know all this anyway. So this is just the upcoming sessions, part of our webinar series. So getting at so what, the interpretive description approach with Rebecca on the 15th of March, grounded theory and action on March 22nd with Dr. April Pike. And then we have the critical appraisal of qualitative research with Dr. Karen Parsons on March 29th. To register for these events, you can go to the NL Support Eventbrite page. And you can also check out past events there. I wanted to just let people know about our free training program. So there's monthly webinars. This one would be included. So they're in 6 sessions. One should be completed in person, but with COVID, we've been doing them virtually. You can sign up for these events at nlsupport@mon.ca. And if you have any questions at all about the events or training sessions, please reach out to me at amy.hand@med.mon.ca. So if that's all, I guess that's it. Thank you, everyone.
All right, thank you.
Thank you,
everyone.
bye. Thanks. Bye.
Bye-bye.